Okay, well, I hope everyone had a good lunch. Our second panel will explore preventive actions to remediate health disparities within the disaster context. Mr. Jonathan Purtle is a research associate at the Center for Nonviolence and Social Justice at Drexel University. Prior to that, Mr. Purtle worked as a program manager and health policy analyst at the Drexel School of Public Health, where he worked on a range of projects relating to health disparities, healthcare reform, and public health preparedness. Mr. Purtle will talk about the interactions between disasters, social justice, disparities, and trauma. After that is Mr. Godfrey Jacobs. He's the program manager for SRA International, where he leads the health disparities practice. He's an expert in cultural diversity issues and the needs of special populations, with an emphasis in health disparities. He will speak about strategies for reducing health disparities in disasters. We'll take questions after Mr. Purtle's session because he is actually heading back to Philadelphia. So we'll take questions then and then questions after the second speaker as well. Thank you.
Good afternoon. Thank you for sticking around here. So as Dean Thomas did, and did very well, I'm going to kind of take a couple different perspectives here and put them together based on where I'm coming from. So for about 4 years, my first job out of graduate school, I worked on projects specifically related to racial and ethnic disparities in disaster outcomes. This was post-Katrina, and these were 2 projects funded by the Office of Minority Health at the federal government. But about 2 years ago, I gave that up to go back to school full-time and get my doctorate in health policy and social justice, where my research is focused on psychological trauma and health. So given this journal's focus on social justice and the topic of the symposium, I thought it seemed fitting to kind of meld these ideas of social justice, trauma, disasters, and disparities together and show how all of these factors interact. So just to give a quick overview, I just want to give a background. I think the other speakers did an excellent job at just the history of racial and ethnic disparities and disaster outcomes. And then I want to talk about social justice for a minute, just because it's a term that's widely used as a rhetorical device, but people often don't define it, and there are a lot of different definitions for it. You guys are law students and legal scholars, and I'm sure you have many thoughts about it as well, but I just kind of want to give a working definition for this presentation. And then briefly I want to talk about psychological trauma, what it is, and then talk about some racial and ethnic disparities in mental health following disasters, and then touch upon a way forward, what we can do to address these disparities, and talk about some of my prior work that was supported by the Office of Minority Health and the recommendations that we came up with. So just a brief overview, as I'm sure you guys agree with by now that there is this legacy of racial and ethnic disparities across all phases of disasters, and it goes well beyond Hurricane Katrina. So minority groups are less likely to be prepared before emergencies. The Behavioral Risk Factor Surveillance System is an ongoing survey conducted by the CDC, the Center for Disease Control and Prevention. They found that minority groups are less likely to have disaster kits and have a disaster plan and all of that good stuff that we tell people to do. They're less likely to hear and comprehend the warnings to evacuate. And also they live in areas that are higher risk for disasters due to geographic vulnerabilities and then structural vulnerability in the very concrete housing structural sense. During disasters, they have higher rates of mortality, morbidity, and injury. An interesting study that was done by the Indian Health Service, which is the federal entity responsible for Native American health, they went back and looked at how Native Americans fared during the Great Pandemic of 1918, and they found that they had a mortality rate 4 times that of other racial ethnic groups. And then during the H1N1 pandemic, much more recently, we see this 4-fold disparity in mortality, again, between American Indians and Alaska Natives and other racial ethnic groups. So this is not anything new at all. Greater relative economic loss, and then after disasters, minorities encounter greater barriers to receiving recovery assistance and navigating the bureaucracies that are in place, and have greater lingering psychological effects, which is what I'm going to focus on today. So, what is social justice? And I really think it depends who you ask, and I think in part that's because justice is, by definition, a social phenomenon. So as Dean Thomas said, law is cultural, and similarly I think justice is social and something that we construct socially. So I like David Miller's definition of social justice, which is how the good and bad things in life should be distributed among the members of a society. So on what determines who gets what, instead of just looking at the end distribution, how do we decide who gets what? And in America, we like to think of meritocracy as the way that gets sorted out. But I think, as we know, there's not the preconditions for a meritocracy to work as it's supposed to aren't necessarily in place. So to kind of illustrate this a bit, a professor of mine says that social justice is like a deck of cards. So if a deck is well shuffled and you deal the hands out, and people get different hands, and some hands are better than others, we don't really consider that an injustice because we came to that end, by a fair means. But sometimes the deck is stacked, and the same people keep getting the better cards again and again and again. And I think that's a pretty illustrative way to think about social justice. David Miller also talks about the circumstances of social justice and what needs to be in place to talk about social justice in a meaningful way that can guide policy and guide change, as opposed to just kind of a theoretical device. So we need a balanced society. If we're worried about how the goods and bads are distributed among the population, we have to have boundaries of that population. And Miller thinks that a country and nation state should be the boundaries of that population, as opposed to looking at social justice globally. And I think a reason for that is we need an identifiable set of institutions that we can identify and implicate as perpetuating social injustices, and know that if we change something within that institution, we will have an outcome aligned with what we think is social justice. And we also need an agency capable of changing the institution. So if we identify what the social injustice is, how it's being produced, we need a way to change that institution in the way that we want. And that is normally the state, the government, through policy and law and other means. And lastly, we need broad consensus about what are the goods and the bad. What are the goods and bads in society that we're concerned about when we're thinking about social justice? And here are some of them. So John Rawls said that, these goods are anything that a rational person would want. And fair enough. I think that these are all things that we want. Healthcare, income, safety, housing, time for leisure, full political participation, opportunity, education, transportation, and ability to get around. These are broadly a non-exhaustive list of the goods of social justice. And I think it's fair to say that in American society, we do not have social justice, as evidenced by disparities in access to health care, even among the insured, racial and ethnic disparities, in insurance status, the way our education system is financed, and the fact that if you're born in a low-income community, your chances of getting a high-quality education are much, much lower. Felon disenfranchisement laws that have 13% of African American males of voting age unable to vote. We have social injustice in the United States. So the reason I say this is because I think we talk a lot about, structural inequality and institutional racism. And I think when thinking about disparities in mental health outcomes after a disaster, this is kind of an interesting and productive framework to think about how social injustice increases vulnerability to adverse mental health outcomes after disasters, and how these patterns play out across different racial and ethnic groups. So I want to talk about trauma just in one slide and define trauma. This is a definition of trauma by a psychiatrist, which I like. He says, traumatization occurs when both internal and external resources are inadequate to cope with an external threat. So trauma is a totally subjective phenomenon. What is traumatic to one person very well may not be traumatic to another person. And I think a lot of these resources, these goods of social justice, can serve as buffers, as internal and external resources to buffer the effects, the traumatic psychological effects of a disaster. And when we have social injustice across these different goods, we have increased vulnerability for adverse mental health outcomes in minority communities. So to go beyond kind of this theoretical stuff and ground it in some more empirical evidence, Fran Norris is a kind of a PTSD epidemiologist, and she reviewed all of the literature around mental health outcomes in disaster between 1981 and 2001. So she reviewed 201 studies, and the total N, if you pooled all the people in all those studies, it was over 61,000 people. So she wanted to kind of take the empirical literature and really take a look at what are the predictors of adverse mental health outcomes after a disaster. And here's what she found. She found that income was highly correlated with PTSD, major depressive disorder, anxiety disorders, things of that nature. Prior traumatic events, such as witnessing community violence and all sorts of things like that. Level of educational attainment, chronic stress and levels of community stress, and a strong internal locus of control and sense of control is very protective against the adverse mental health outcomes of disasters. So this was pre-Hurricane Katrina, pre the 9/11 literature, and there were 11 studies that collected data on racial and ethnic minorities and could tease out disparities therein. And all of the studies among adults found that minorities suffered a disproportionate amount and severity of adverse mental health outcomes, and 4 out of the 6 of the studies among youth found the same. So take a look at some of these studies. Let's pull out 4. So this is symptoms of PTSD 6 months after Hurricane Andrew. The study was published in 2002, but Hurricane Andrew was in the early 90s. But as you can see, Hispanics had a rate of PTSD twice that of non-Hispanic whites, and African Americans also had a much higher rate. When you went down and looked into what are the characteristics of the Hispanic community who had these high rates of PTSD, they had greater exposure to the disaster, because they were less likely to evacuate, but they also had more stress in their communities beforehand and much lower levels of educational attainment. So this study is kind of interesting. This is a study of 4th and 9th graders in Hamlet, North Carolina. So in Hamlet, North Carolina in 1991, there was an industrial fire, and the children weren't actually in the industrial fire, they were in the community where the industrial fire happened. Obviously a lot of their parents worked at this industrial plant, and there weren't any racial disparities in mortality between blacks and whites who died in the fire. But we still have this disparity in symptoms of PTSD between African Americans and whites following the disaster. So this is something in the psychology literature we refer to as vicarious trauma, where people who are not directly exposed to a traumatic event, but people in their lives are, and they become symptomatic as a result. This is a study post 9/11 of New York City residents 6 months after, and this author looked at differences within Hispanic groups. So Hispanic is often, just grouped together in the literature, and this researcher was wise enough to tease that out and see what their country of origin was and what their ethnicity was. So it wasn't part of this study, but in a similar survey that was conducted around the same time period, the PTSD prevalence among African Americans was around 8%, and among non-Hispanic whites it was around 5%. And here we see other Hispanic groups, such as Mexican Americans, it was 6%, but for Puerto Ricans and Dominicans, it was 13% and 14%. And again, if you look down at the characteristics within that population, they had lower levels of educational attainment, lower income, and less social support. And lastly, this one's a little bit different. So this is a post 9/11 survey, again, 1 full year after the event, and everybody in the survey had major depressive disorder or PTSD. And the author wanted to look at service utilization. So in theory, all of these people could benefit from counseling or some sort of therapeutic intervention to deal with the sequela of the mental health sequela of the disaster. And across the board, African Americans had lower rates of mental health service utilization than whites. And this was, I'm not sure if they controlled for insurance status, but this was also a time when there were a lot of free mental health services available in New York City. And I think this study kind of shows another issue, and it's lack of trust in the medical institution among minority groups, which is the result of social injustices of the past, such as the Tuskegee experiment and the whole range of medical experimentation that went on back in the early 20th century. So hopefully at this point I made a somewhat compelling argument that we have social injustice in the United States, and that social injustice in turn increases vulnerability to adverse mental health outcomes after disasters, and also increases exposure to the disaster itself. And then we have these disparities in mental health outcomes. So what do we do about it? And this question was what we were charged with through the National Consensus Panel on Emergency Preparedness and Cultural Diversity. Now our focus was not just on mental health outcomes. We kind of took a wide view of thinking about what we can do as a nation and what are some best practices that could reduce racial and ethnic disparities in mental health outcomes. So to talk about the origins of the project a little bit, two of my colleagues, Dana Sandroulis and Nadia Siddiqui, after Hurricane Katrina and all the poignant imagery that came out of New Orleans, they went to the literature and they poked around to kind of see, all right, is this something new? Are there best practices about what to do to address these issues? Kind of what's the state of the art here? And what they found was that there was indeed, some research about the issue, and there was this legacy of disparities, but there was no real concrete guidance about what to do. And there was also there was this polarization across different fields. So people in sociology were researching the issue, looking at it one way. People in public health were looking at it. People in emergency management were looking at it. People in psychology were looking at it. But everything was very, very siloed, and there wasn't any really coherent guidance about what to do. So they got support from the Office of Minority Health within the U.S. Department of Health and Human Services to convene this panel of 33 experts from different organizations across different sectors across the country. So FEMA was at the table, American Red Cross, the American Medical Association, the American Public Health Association, Columbia, Drexel, academics, community-based organizations, community advocacy organizations like National Council of La Raza, which is concerned with Hispanic communities, and Access, which is concerned with Arab American communities. And we got everybody together, and our goal was to produce some sort of guidance to impart upon national, state, territorial, tribal, and local agencies and organizations on the development of effective strategies to enhance preparedness and eliminate disparities for racial and ethnic minority communities. So it was a pretty tall order and a pretty broad take that we took on it. And our target audience wasn't necessarily the general public. It was people working in public health, people working somewhere within the field of emergency management, or people who were going to be providing services to individuals following disasters, or people that were, involved with planning activities. So we produced three things. We produced a national consensus statement, which was much more complicated and hard than one would think, getting all these different organizations to sign off on a paragraph describing the nature of the problem and broadly what we should do about the problem. So accompanying the consensus statement was a set of guiding principles offering kind of key areas that we should focus on to reduce these disparities. And in 2011, we operationalized those guiding principles and produced a toolkit which kind of provides what organizations can do to address these issues. So I'm just going to provide a pretty broad overview, mainly because you guys are law students and a lot of our guidance was specifically for people, working in public health and emergency management. But I want to outline a couple of the underlying themes. And the issues of culture, language, and trust kind of underlie all of this work. So knowing that racial and ethnic minorities disproportionately bear the burdens of disasters, time and time again. And it's complex, the causes are very complex, and it's really difficult to tease out causality, but we do know characteristics about this population that is at high risk. So we think that it's really important that emergency preparedness and response strategies take into account cultural considerations, issues related to trust in government, trust in the medical profession, and then of course language issues as well. But because these issues are so, I don't want to say issues, these characteristics are so heterogeneous and diverse, we couldn't kind of be prescriptive and say this is the way to best address, African American communities with risk communication messages. This is the way to be culturally sensitive when responding to Hispanic communities. So another underlying theme was the importance of community engagement and really partnering with people at the ground level who know the community, know their needs, know their assets, and know how they will be best responsive to the services we want to provide. And then also thinking about emergency preparedness, response, and recovery within this much broader context of social, economic, political, and health priorities. Especially when we talk about preparedness, the need to have extra water and food and have a, evacuation plan and all that stuff. It's a pretty difficult and almost unrealistic sell to a community that's in poverty with high rates of community violence, and every day is an emergency, and we're asking people to invest their finite resources in food and water for this outcome that may or may not happen in the future. So really kind of taking the broader ecological perspective when talking about preparedness. So a couple concrete things that we recommend, and I call these ameliorative approaches because, as I'll show in the next slide, I think at this point we agree that the root causes of this are much more embedded in social structure and structural inequity and institutionalized racism and things like that. But these are strategies that we think could help reduce the disparities we see time and time again. So one, of course, is community partnerships and government partnering in a real meaningful way with community-based organizations, faith-based organizations, and ethnic media outlets. So this is something we talk about a lot, but I feel like, and the panel felt like, it's not always meaningful. Meaningful means, joint priority setting about what are the priorities in the community, and also incentivizing them to be there. Often we have this context where the government officials are, being paid to be there and invest their time in this planning effort, and the community members aren't. They're just there. And we felt that it was really important to move beyond that and have joint priority setting and incentivize community members to take part and really show them that we value their time and input. Another issue is cultural competence, mental health training for first responders. So this is tough because, most mental health therapies and the field of mental health are pretty much, from a white European perspective. So we do have training for first responders about psychological first aid and how first responders should interact with victims of disasters and how they should offer them services and how long you should wait and all that stuff. But it's all pretty much from this white European perspective. So we have this body of cultural competence training, which I think, are you going to talk about?
Somewhat.
A little bit.
Yeah.
But culturally competent training around mental health for first responders. And then lastly, targeted risk communication strategies. This means, of course, using the right language. In Hurricane Katrina, I know there are a lot of stories about, there were large Vietnamese and Hispanic communities with very low levels of English proficiency, but all of the warnings were only in English. And then we wonder, why people didn't evacuate. And of course, they probably got word that the hurricane was coming, but you have this whisper down the lane effect where somebody hears it, it gets translated, if you hear from a friend of a friend of a friend. So the panel thought a true priority was to really reach people through the mode of communication that they prefer, be that written ethnic media, radio, or through trusted community-based leaders. So government entities going right to churches and community-based organizations, community centers, wherever the locus of social interaction is in that community, going there and having them disseminate these messages out through the community. And then I think the fundamental approach is really, identifying the social injustices beyond the context of public health and disasters and promoting policy change. So, broad things like housing segregation, education, financing reform, felon disenfranchisement, all these kind of macro issues of social injustice that appear to be outside of the realm of public health and disasters have these trickle-down effects that do increase vulnerability for all sorts of adverse outcomes in disaster contexts. So I want to end with a picture. This picture is not copyrighted, but it's hard to visualize. I think social inequality, and it's hard to visualize disparities, but I think this kind of sums it up. So this is a picture post-Hurricane Katrina. This is Mississippi. And, disasters, they don't discriminate. They roll across, natural disasters roll across a geographic area. But time and time again, we see these disparate outcomes in racial and ethnic minorities bearing a disproportionate burden. So for some people on the left side, the disaster happens, they're affected, they recover, life goes on. But for other people, they don't. And be that death or injury or total economic ruin and lingering mental health effects, we see these patterns again and again and again. And finally, this is a project that I worked on. It's called diversitypreparedness.org. It's a website completely devoted to the issue of racial and ethnic disparities in disaster outcomes and what we can do about it. So the peer-reviewed literature is on there, best practices, guiding principles for people working in the community. We try to take everything from all these different fields and organize it into a user-friendly way that can be navigated. I'm not in charge of it anymore, so if you see errors, it's not my fault. But it's still up there, and I think it's a really great resource for people working in the field, and just if you're curious about this issue and want to poke around and kind of get a better sense of the totality of it, I think it's a really good resource. Thank you.
Question for Mr. Purtle now.
Yeah.
I find the psychological trauma information to be very interesting. One of the questions I had about it is if there has been an effort to control for the lack of resources available that create the psychological trauma. So it could be that minority populations have more psychological trauma even with the same resources as non-minority populations, or it could be that the psychological trauma simply arises out of the lack of resources available to them because of their being in the minority population.
Right. I think it's both. I think this idea of lack of resources, be them economic and educational, that whole social fabric increases vulnerability to any potentially traumatic exposure, right? So be that a disaster or community violence, I think the level of vulnerability to any semi-objectively traumatic event is higher because the community is so stressed to begin with. But I also think that there's more exposure to trauma in these communities. I mean, I work now around issues of community violence, so that's kind of where I'm coming from. And the kind of constant exposure to violence and toxic levels of stress really increasing vulnerability. If that answers your question?
Yeah, I mean, I think you've answered based in part on your experience.
Right.
I'm curious about whether the literature, I'm also curious, not just asking about it, but whether the literature has made an effort to control for, there's a cause and effect problem. Right? So what I'm interested in is if you have two similarly situated populations in all other respects, would minority populations suffer greater psychological trauma. So you showed us the study, for example, of the fire, right, the industrial fire. But one question is whether that controls for socioeconomic status, right? If we have two socioeconomic groups that are the same, will there still be the same disparity between whites and blacks?
Right, and I'm not sure. Right, you're talking about if you statistically control for income and other things. I'm not sure.
There aren't any more questions.
Okay.